it's setting up onto the YouTube. Just give me a second. Once it will say, I will let you know, and then we'll crack on. Once it will say, I will let you know, and then we'll crack on. Good evening, everyone. Thank you for joining us. Here we are in our ELSA TV channel third episode, and we are very excited to have Professor Philip Chiu with us, who is a professor of surgery and dean of medicine in Chinese University, Hong Kong. A brief introduction about Professor Philip Chiu is currently professor and honorary consultant and head of division of upper GI and metabolic surgery in Department of Surgery, Princess of Wales Hospital, director of multi-scape medical robotics center, director of Chinese University Hospital, CUHK Technology Center for Innovation Medicine, and associate dean, Faculty of Medicine, the Chinese University of Hong Kong. He also served as the director of endoscopy and Princess of Wales of the hospital and the New Territories East Cluster Hospital. And also he's one of the pioneers in doing the world first robotic in ESD and ER in later on in colorectal. And with me is my co-host, Dr. Aung Myint, who is a senior consultant at Tan Tock Seng Hospital. He is an upper GI and bariatric consultant, director AST Center into the Tan Tock Seng Hospital. Thank you, Professor Chiu, for joining us, and thank you, Aung, for joining the third episode. Professor Philip Chiu, just a brief introduction. Thank you for joining, and before cracking on to the questions and for the audience, if you want to say anything about yourself, please. Thank you. That would be great. If I'm missing, because it's a long thing which I'm basically missing in your CV, that would be great for our audience. Thank you so much.
Thank you, Sajid, and also thank you, Aung, for your kind introduction and invitation. So, well, you don't miss a thing, and most important is actually now I'm serving as Dean of Medicine at the Chinese University of Hong Kong. That's probably the only title that required for me now, but I trust that I'm really related to ELSA because I'm the immediate past president of ELSA. And of course, I'm really, really honored to be joining this ELSA live TV channel to share some of my experience with the audience here.
Thank you, Prof. Thank you. Aung, anything you want to, before the crack on with the questions, if you want to say anything, please, as my co-host and also the co-chair of the ELSA ICC committee and involved into the all ELSA DT and IC projects.
Thanks, Sajid, for the kind introductions. It is really my honor to host this event because actually Professor Philip Chiu is considered as my mentor, even though I was not trained directly under him. But when I was a trainee in Singapore, I think Prof. Philip Chiu visited NUHS many times. So actually, I learned a lot from him in the cadaveric workshop and then also the dry labs. So actually, Professor Philip Chiu is considered as my mentor, my teacher. I still learning a lot from him remotely whenever I have a chance to attend his lectures in the congresses or even the some live surgery performed, transmitted live for the endoscopy as well. Thank you, Professor Philip Chiu. It is my honor to co-host with Sajid as an ELSA ICC committee. Yeah, thank you, Prof.
Thank you. Prof, thank you for joining again, and tell us about your personal journey from past to future in robotic surgery, please.
Okay, thank you. So basically, I started as an upper GI surgeon and the training at the, since maybe 2001. that time. And then I actually learned about robotics development by knowing the research paper that was published on the transatlantic operation. And that is really, really impressive at that time. That was the Suez system, and it's still not yet the current Da Vinci. And then afterwards, I learned that the company acquired and then merged together and become the development of the first generation of Da Vinci robot. At the same time, after my overseas training, I come back to the Department of Surgery, Faculty of Medicine, Chinese University of Hong Kong, and then the first robotic system of Da Vinci was acquired by the Chinese University of Hong Kong after setting up a minimally invasive surgical skill training center in 2005. And then we started to develop the robotic surgical surface for the upper GI surgery. And I remember that my first robotic esophageal surgery was actually performed in 2009. That time, probably one of the pioneer, and we actually have to develop, including the post site insertion, all the way to the procedure development. So we selected a more stepwise approach to introduction of this robotic esophageal surgery from a benign disease to a malignant disease, and from the enucleation of esophageal myeloma to fundoplication to hairless operation, and then eventually towards malignant and treatment of esophageal cancer using the robotic esophagectomy. So I think that is a stepwise approach for us to introduce a new technology for the division, and also to be safely partner with different team members so that they also understand how we actually perform robotic esophageal surgery. And then I then conduct and perform the performance of minimally invasive and robotic assisted minimally invasive esophagectomy, which is in our locality a 3-stage procedure for treatment of squamous cell carcinoma of esophagus. And then afterwards, I think there will be also in parallel the development of free phase and free field lymph node dissection for esophageal cancer for squamous cell. And then I found out that actually the robotic system allow us to have a much better dissection, especially for superior mediastinal lymph node dissection. So with that, I actually performed the robotic assist minimally invasive esophagectomy, focusing more on lymph node dissection, especially in the superior mediastinum. And I found that is an advantage. And I trust that at the same time, in parallel, because I learned the robotic technology from the use of the surgical minimally invasive surgical system, I actually in development of a endoscopic robot. This is in partnership with the Singapore group, including Professor Lawrence Ho from National University of Singapore and also Professor Louis Fee from Nanyang Technological University. We actually pioneered the first flexible robotic system for performance of endoscopic submucosal dissection. So all along the way, and we did actually the first endoscopic robotic gastric ESD in 2011, and then afterwards, after many refinement of the system and also preclinical testing in the porcine model, we actually bring this forward to robotic colorectal ESD in the year 2020 in the Chinese University of Hong Kong. And right now, we already completed the clinical trial on 43 cases of robotic colorectal ESD. So using the EndoMaster system. So this is not the end of my journey, because I think it's just the beginning, because that actually opened up the area of endoluminal robotics. And I think that in the future, we will focus more on the endoluminal robotics, not only in the dissection part, but also in the tissue approximation part. We are developing also the robotic suturing method. And then afterwards, in the future, maybe also a little bit on the nano robotics technology introduction. So it is still just the beginning of the era of endoluminal robotics.
Yeah. Okay. Thank you. Thank you. Aung, please.
Thanks, Prof. It's a very amazing your journey. I think that since I was a trainee, you told me about your vision of the endoscopic surgery. I still remember when you was It was a poem course. I think you came to Singapore with the Professor Jimmy So the time. I was still the registrar at the time. And then you shared about your, the passion to the endoscopic surgery. That time, not many surgeons are doing the endoscopic surgery. And also, if I remember correctly, that not many gastroenterologists are also doing about the endoscopic surgery. But the time you mentioned that there is endoscopic surgery will be the future, right? So I think with this, I still recall that conversation when I was a trainee, maybe more than 10 or 15 years ago. So I would like to ask your opinion, or what is your the personal journey of your how to embark on this endoscopic surgery that time, and also to share with us on the what you envision about endoscopic surgery, especially you touch about the robotic endoscopic surgery as well. Thank you, Prof. Yeah.
Yeah, so if you look into the current mega trend in development, one of the important development is in fact non-invasive diagnostics. And the other is in fact the government worldwide is also pushing on screening for early diseases, especially for cancer. And then if you look into the endoscopic diagnostic, then you find that also there's an increasing adoption of AI. So all this technology, for example, like non-invasive diagnostic, it was actually used and pioneered by our professor in the Chinese University of Hong Kong, Professor Dennis Low, who actually developed the technology of non-invasive diagnostic for Down syndrome for prenatal testing. And the same principle can actually apply for detection of early or cancer detection, just treating a cancer like a baby in a mother's body. So that the same technology is now pushing. And then secondly is about the government, which is already implementing screening program. Colorectal cancer is one of them, which has been delivering the colorectal cancer screening program worldwide. And also, I think the AI technology, which will allow us to have a better standard of endoscopic diagnostic, including the quality of the diagnostic endoscopy, and also the detection of early diseases assisted by AI. And all this, I think, will end up in only one endpoint, which is early diagnosis of any GI disease or any diseases. And then you would be now thinking that if you have an early detection of cancer in the GI tract, the way of treatment is not surgery, it's actually endoscopic resection. Then you believe that in the future, if you are better in the patient care, a better disease care, then the patient do not need to receive surgical resection of the patient's organ, because the organ is actually been there for a purpose, for your human body function. Then a better outcome will be just endoluminal resection of any early detected diseases. Then endoluminal surgery will become more and more important, and it will be developing into a state that we might actually receiving a higher proportion or a higher treatment with endoscopic surgery as compared to a laparoscopic or a conventional surgery. And I think we need to adopt that. And you can see there are trends. For example, in the cardiology, in fact, there's a lot of cardiac disease now being treated by cardiological intervention rather than open heart. And then think about the Japanese model. If you can detect more early gastric cancer, nowadays in Japan, more gastric ESD is being performed as compared to gastrectomy for treatment of gastric cancer. And this is just an example to tell us that in the future, there will be more endoluminal procedure being performed. And I think that as a surgeon, we should embrace on the endoscopic treatment as well.
Thank you, Prof. And also you mentioned about something as being a surgeon and also being an innovational surgeon, basically. Technology is always there to help us in terms of improvement and seeking guidance from the technology. But being a surgeon, we better know, in a sense, I would say we have a better sense to use the technology in how the technology we can incorporate in our practice. So there are different models around like Intuitive, DaVinci, and Hugo. And I was with you in Dubai in a meeting, and then I saw a platform which you have built basically for being a surgeon. So tell us briefly about that system, because that is very exciting when a surgeon is working as an innovational technologist with the industry to develop a system which is basically need for the surgeons.
Yeah, so because recently, over the past 5 years, in fact, the Hong Kong government has been pushing a lot in innovation technology development. And then one of the important frontier for Hong Kong is, in fact, healthcare innovation. And through a major, grants from the Hong Kong government, we have established a multi-scale medical robotics center. That is a collaboration between a surgeon and an engineer. And I am the director, co-directing with my engineer partner, Professor Samuel Aung. And we are, the objective is, in fact, to bring the basic technological advancement from engineering all the way to clinical application. Clinical application and clinical trial is our goal in the center for all the projects. And one of the important development for us is also the inception of a startup company through a basic technological translation of IP from the university all the way to the startup company. And then that is actually led by my engineer partner, Professor Samuel, to establish a startup company called the Cornerstone Robotics. And we actually developed a new robotic surgical system that we are actually absolutely pioneer starting from scratch. And now this surgical robotic system, which is having a 15,000 parts, including motors, gears, every wire. And then we actually assemble this and produce the prototype. And we have actually been testing and refining this through multiple preclinical trial using animal model and cadaveric model at our center. And then afterwards, improving on this system. And then basically we push this system all the way to clinical trial in the year 2022 in August. And we started our first case. And then now we have completed 55 procedure in Hong Kong, including upper GI, lower GI, and also urology. And at the same time, the system also tested in 100 procedure in China, focusing on urology. So we are now targeting at the registry approval from NMPA in China. And I think this is an important experience for me also to understand that for a surgical robotic system, firstly, for things that, like because the conventional DaVinci robot has been there for 20 years, some of the patent has been passed, and there's something that you don't need to reinvent the wheel. In an innovation, for example, you don't need to do innovation just because you want to do innovation. So for a car for driving, so I think you don't need to reinvent the wheel. That's the jargon, right? So if you wanted to drive a car in Hong Kong, in Singapore, in Malaysia, in England, you don't need to have a different kind of a driving system if the patent is already been expired. The surgeon, if in consideration of the safety for any kind of robotic system, if you can sit there and in 5 seconds, you immerse into the operation and do the same operation using the same system of driving the robot, I think that is important for the surgical safety, firstly. Secondly is that the control and also the system that we can control and drive the robot should have a certain level of quality of performance. You cannot sacrifice that high quality robotic performance or experience by a less intuitive way of driving the robot. So the robot have to be in the same quality of performance. And the third thing is that the accessibility of that robotic system, because now you can see more robotic company is coming up with a new surgical robot. And I hope that that is also what, I mean, every single surgeon wanted, is to have a robotic system with a reasonable price, but high quality of performance. So if from the past experience of any conference, ever since I started into the research of the robotic surgery, I already, for all the conferences that I attend, the question is always, how do you justify the increased cost? Because the performance is almost the same or sometimes a little bit better as compared to conventional minimal invasive surgery. But then because of the robotic system and the kind of robotic arm and that we need to use, and also the instrument cost, there's always an additional cost as compared to conventional minimal invasive surgery. How do we justify that? I think if we can have a reasonable price a robotic system, of course, a lower price than currently, but then a similar performance, high performance of robotic system, then I think this question probably can be answered. But then at the same time, I think the surgeon have a better advantage because the ergonomics is better. So our wrist arms do not need to stretch there, especially if I do, minimal invasive esophagectomy, I need 8 hours. So thinking about this for 8 hours, if you use a robot, then for us physically, for our health, for our joints, everything is better. And secondly, the precision of dissection is also better by the robotic system. So, and then the quality of oncological clearance of this lymph node dissection is also better. So I trust that the cost is an issue. So accessibility by cost, by the other instrument cost, hopefully can be reduced so that we can have a better or more patient being benefit from the robotic surgery, as well as more surgeons being able to benefit. And think about the next generation. They would be easily adopting to the robot because they are already engaged a lot with the current, handheld device, telephone, mobile phone, everything. So they will be very much welcome.
Welcome with the technology. And they're very, very familiar with the technology already, as we used to be like, we saw the very dynamic change from black and white TV to the color TV, from telephone to the mobiles to the thing, but they are already on it. Yeah. On, please.
Yeah, thanks, Prof, for your very insightful for technology innovations. Yeah, so just that you also perform endoscopic surgery. Endoscopic surgery has a different challenging set, especially for us as a surgeons, right? Because current endoscopy, until you manage to develop the future robotic endoscopic surgery using a two-hand technique, I think currently we are limited by the current endoscopy for endoluminal surgery. So I would like your advice on how to share with the junior residents or trainees. How do you overcome the advice for overcoming the learning curve of the endoscopic surgery until the technology is more advanced to have a robotic, which I know that you are developing one in the Hong Kong Chinese University as well. So please advise the junior doctors, how can you overcome this learning curve of endoscopic surgery, which is a very challenging surgical techniques. Thanks.
Yeah, thanks. So firstly is that when we look into the standard, the usual standard that we look into is the Japanese. And if you look into the Japanese endoscopists, they are really focused. They have a high volume of, like ESD procedure, and they do not worry about the training. But a lot of time when you look into how do we, spread or promote this technology to the worldwide, then every country has a different health system and organization, as well as a team-based treatment. So if you think about, in Japan, you can just do colorectal ESD or upper GI gastric ESD for the whole career, just focus on one procedure. But, they are having the spirit of a samurai. It's like a samurai, but we are not practicing like a samurai. So we need to think about our training system, how do we achieve excellence in endoluminal surgical procedure? So, for example, if we ask, in the past, Japanese, how do you start ESD? They would say, okay, start gastric ESD first because it's easy. You learn the technique and then proceed to rectal ESD and then proceed to right colon ESD and then subsequently esophageal ESD. The final frontier is duodenal ESD, which is the most challenging. Even the Japanese, only a few experts can do. But then this model cannot apply immediately in the Western world because there's no gastric ESD, there's no early gastric cancer. So how do you do that? So I think you need to, mix a few skill sets together to make up the volume. For example, if you're upper GI, so for my team, we are not only considering gastric ESD as the endoluminal surgical procedure for training. You can lump the esophageal ESD, gastric ESD, and then the POEM procedure, and then the submucosal tumor, where you do tunneling technique, and then also endoscopic full thickness resection, everything lumped together as a training for endoluminal surgery for upper GI. Then you have a reasonable volume. And secondly, you need a mentor. If you don't have a mentor, you don't have a trainer, you cannot do that. If you don't have a trainer, so there's a few options. For example, like going overseas, abroad for a fellowship, a time. So I think a few centers in the world actually provide you with hands-on training, including us in the Prince of Wales Hospital, endoscopy, we have hands-on training. So, and then thirdly is how do you start the first procedure? So there are a lot of ways. Of course, you can, if you have a good mentor in the same country, you can ask them to come and support you. But then at the same time, I also have in one time served as a professorship with National University Singapore, where I visited frequently and helped the team to develop and pioneer those procedures. So I think overseas, expert coming to help and also one of the options. And fourthly, use technology, because nowadays, today we are also doing this webinar. You can actually do a online, tele-mentoring with the expert. If they agree, then you can do online tele-mentoring. So maybe not as best as, sometimes a mentor on-site, because mentor on-site, some of the a little bit trick and also maybe difficult step, maybe just 5 minutes step, the mentor can overcome, then you can smoothly conduct the procedure. But this is probably better than none. So if you can do a tele-mentoring like using this kind of platform, I think this is also advantageous. And of course, continuously update your technique with meetings. So joining conferences and meetings, for example, ELSA conference is very important. So come and join scientific major meetings. And I think ELSA also have pre-congress workshop. And this is also important for you to learn. Even if you are doing the ESD, you might actually learn from doing this, like pre-congress workshop and communicating with experts, learn a few tricks after the conference, and then go back and then continue your practice.
Thank you, Prof. It's very insightful, especially mentioning about the role of the mentor and the mentee. Basically, just like Aung, you were my indirect mentor. 2017, you might not be remember. First time when I met you in South Korea in Seoul for endoscopic workshop on Apple's platform, APELS, and then back in Thailand in 2019 for upper GI endoscopy. And then that was the first time, basically, because I was trained in a part of the world where the surgeons are not doing endoscopy at all. That is the role of the gastroenterologist, our colleagues who are basically doing, and you are relying on. But later, when I did my fellowship in Singapore, as you said, under a mentor and Professor David Lumanto, the name appearing instead of my name, Sajid Malik, I'm happy to use his name onto the platform. So give us thank you for mentioning about the samurai as well. Kiyotaka Imamura from the Japan highlighted it many times onto the ELSA platforms as well. As a warrior, we need to learn and under some mentor, and that is the only way. So give us your suggestion, working with your fellow colleagues in the gastroenterology, especially sitting into the Asia, not into the modern part of the Asia, but the major part of the Asia who is still in a learning phase, especially into the South Asian countries, where surgeons are not involved in doing endoscopy at all, and how they can basically collaborate with their fellow gastroenterologists to overcome the endoscopic techniques and to work in a better way in minimal invasive surgery.
I think firstly is that you have to be friendly with your gastroenterologist. That's for sure. And our model in the Chinese university, we actually start by forming a team of researchers. And the leader at the previously will be Professor C.D. Chung, together who is my mentor surgeon, upper GI surgeon, and together with the leadership Professor Joseph Song. So some of you might know him as a very renowned gastroenterologist. And of course, my former dean, Professor Francis Chan, also gastroenterologist. And we have been an excellent team together. And we start by doing actually groundbreaking research in management of ulcer bleeding. We actually basically changed the method of ulcer bleeding from surgery to endoscopic management through various large-scale randomized controlled trial, and also the use of the adjunctive high-dose PPI infusion to prevent rebleeding. So this is our story of how we actually get together with the gastroenterologist and surgeon. And I think through this partnership, we have also a lot of other groundbreaking work, including the introduction of endoluminal surgery. And I trust that this kind of model is important for us to collaborate to bring the future of endoluminal surgery all the way to your unit. So basically, you need to be friendly with the gastroenterologist. And secondly, give and take. I trust that you cannot gain everything and not giving, because you have to work together. So for gastroenterologists, they are very focused on diagnostic. They have a high volume of diagnostic. So if you want to work as a team, share their workload. And also sometimes manage an emergency, because sometimes they don't have enough manpower. The surgeon can also be part of the emergency surgical team. For example, like on call for GI bleeding in our unit, we are shared in the rota between the surgeon and gastroenterologist to share on call endoscopy for GI bleeding and also ELCP. And I think that is also helpful. And then through research and also collaboration, we form as a team, and also we have a research idea that we share together. And the gastroenterologist is very focused on the study design, and also they will help us to improve on our scientific merit of our study. And the surgeon will actually manage the complication, maybe from the endoscopy. The surgeon will be the final person who can manage all this complication. So instead of separating team and then receiving complication for the gastroenterologist, you might as well just go directly into the very frontier, the first plan of endoluminal surgery, and then help them to establish a program and manage the complication.
Thank you, Prof. So just to highlight a thing to our audience, basically we're learning, we have various platforms onto the ELSA website, as well as educational platforms, as Professor Chiu have also mentioned about pre-Congress workshops. And we are aiming to basically show our all ELSA pre-Congress workshop on our ELSA live TV channel. If you subscribe it, even if you won't be able to travel to our next destination, which is in Bali, in Indonesia, to be planned in August, then we are aiming to demonstrate all the workshops onto the endoscopy, bariatric, upper GI, and all the workshops onto the ELSA TV channel. So that will be a very insight for the colleagues, for the gastroenterology, as well as across the specialties. Aung, please, to you.
Yeah, thanks, Prof. Yeah, so I think that was very, very amazing on the how to bring together different subspecialties. I think in the future, there might be a subspecialty of the endoluminal surgery working together with the expertise of the gastroenterologist together with the surgical expertise, especially moving towards the robotic robot assisted endoluminal surgery as you are developing. So regarding the robot, the robotic technology is more and more mature nowadays, and then some of the patents on the robotic platform has been sort of reached to the stage there, right, that can be open source for us to adopt. So in that opinion, how long do you think is the future, or how fast we can develop the fully robot assisted endoluminal surgeries in the future, Prof? Yeah.
Yeah, so I think very importantly, when you look into the trend, there are evidence to predict the trend. That is important. I think so now you can see that a few startup company has been developing this endoluminal robotics for GI. So take a look into the EndoQuest company, and they have raised a lot of funding. And there's also a few groups, one is from us, Hong Kong, one is from Singapore, the other is also from Korea. They are developing at the same time. And I trust that there's also big company like Intuitive Surgical having the iron system doing endobronchial intervention from robotics. It's not GI, but then look into the whole thing and focus. It means that there are interesting party and startup company into the field. It means that it has a potential. And usually for this kind of research, for a new startup or a new research system, it will take around 5 to 10 years for the new technology to be adopted, into the clinical trial. So you will be looking into the next 5 to 10 years time that it might become mature. And of course, at the very beginning, just like the Da Vinci robot, it is very expensive. But then if you become a cost-effective system, you would be seeing like in the next 10 to 20 years time, that it might become cost-effective, just like Intuitive Surgical Da Vinci robot, the development cycle. And then there will be additional device and also technology being added to this platform. When it become mature. For example, in the endoluminal robotic, I would contemplate the introduction of a flexible robotic suturing device. And I think there's a lot of indication for that. So I think as a bariatric surgeon, you also know that endoscopic sleeve gastroplasty is now being conducted more and more, increasingly adopted. And also the current evidences are also showing that the clinical efficacy of endoscopic sleeve gastroplasty, when there is a market and there's an indication, then the technology will follow. So doing an endoscopic sleeve gastroplasty in an inexperienced bariatric endoscopist require a long time. But if you think about robotic suturing or even robotic stapling technology, then it will quickly improve on the technology and improve on also the performance. And that would increase on the adoption of endoluminal robotics. And of course, that is only the beginning, because then there are much more indication of surgical indication that you can actually do with a robot. And then the future, we would have to also add into AI technology, into enhancing the endoluminal robot. So this kind of robot is not developed like a Da Vinci robot, because endoluminal robot, there's a physical constraint. The arm of the robot is really small, really, really small. And you do not expect a full degree of freedom, like 7 degrees of freedom for like what we are having for the rigid robot. It's a flexible thinking about operating, controlling a flexible robot, which is 150 centimeter inside the GI tract, centimeter inside the GI tract. So it's not like a direct rigid robot. So there's a constraint. So you will be seeing like target-specific flexible endoluminal robot, maybe just a robot system to focus on ESD, another robot system for suturing or endoscopic sleeve gastroplasty or anti-reflux procedure, something like that. So And then the next will be also the nanorobotics development, because now we have a nanorobot which we can actually control by magnetic guidance and image guidance. So this kind of a nanorobot, it maybe is just like a bullet, a kind of bullet. So we are still, like a person who is firing the bullet using a piston. But then when we deliver this nanorobot into the specific site and fire the bullet, the nanorobot is going to be targeted by the magnetic force all the way to reach into the internal organ. For example, like fourth branch of the biliary tree into the hepatocytes, and then deliver a bullet oncological treatment for hepatocellular carcinoma or a pancreatic tumor, something like that. It's beyond our reach by the physical, flexible endoluminal device. But then this will become an extension of what you can do through the flexible robotics. And that kind of research is now ongoing. Maybe you need 20 years time to do such a research, but then you can see the cycle of surgery from open to minimum invasive to robotic. It's like 20-year cycle, 10, 20-year cycle, and then endoluminal. And then maybe in the next 20, 30 years time, when I need the medical treatment, it may become endoluminal and nanorobotics.
Thank you.
Fantastic,
Thank
Prof.
you, Prof.
Sajid, please.
Yeah, thank you. Thank you, Prof. Thank you for making it easier for me to ask the next question. Thank you. There was a big paradigm shift from open conventional surgery to the laparoscopic surgery in early 90s. And there was a lot of hurdle in terms of adaptation of the laparoscopic surgery. I believe that there is a less hurdle at the moment because most of the minimally invasive surgeons who are doing the laparoscopic surgery, they're very acceptable at this stage to accept the robotic surgery, not like when they converted from open to the laparoscopic surgery. So when we are moving forward, so definitely there are some ethical concerns in the learning curve as well as in terms of the offering the intervention as well. So what in your experience as well as in your suggestion, tell us about to our audience basically the ethical concerns in the robotic surgery, how the robotic surgery, being a mentor, you have addressed it, and how the person who is developing a new robotic center, a new basically establishing a new center basically can overcome all these ethical concerns.
Thank you, Sajid. So I think the first ethical concern in the past when we adopt the first robotic system is that if there is any medical error or any injuries, is it related to the robotic system or is it related to the surgeon who is operating with the robotic system? But at this moment, we are not talking about automated surgery. We are only talking about an extension of the surgeon's hands and their eyes through the robotic system into the operation. So with that, I think if the performance of this robotic system is robust and there's no error, that is technical error during the use of the robot, then I think the responsibility is still from the surgeon in operating. But I think this platform of robotic surgery, it will evolve into something like a AI co-pilot and then semi-automation. And then automation. So this is a natural, development.
Yeah.
Think about the current development of automated driving. If you have a vehicle, if you have this AI system, if you have the, internet connection, and also electric car, I think this is a natural development also in terms of the, automated driving. And then you also think about the same technology in automated robotic surgery.
Yeah.
Then I think the ethical issue will become stronger and stronger as to, when you do a new technology introduction, is it safe for the patient, firstly? And secondly, is it legitimate for the robotic surgery to be even think about semi-automation, if not automated at all?
Okay, yeah.
So semi-automation. Yeah, semi-automation meaning that you still got a pilot when you're semi-automated a plane. nowadays, most of the procedure of a flight is in fact automated. But there are still essential steps that a human should be there in control. So think about that. Then, that you have to be pretty sure the technological development is up to the standard. For example, the AI have to be very robust. And secondly, is that the robotic technology development require haptic feedback. This haptic feedback is not for us. Actually, this is for the robotic system to have a feel about the tissue tension and not to injure the tension if they are doing the automation or semi-automation, for example, like suturing. The haptic feedback is actually for semi-automation. For us, we have already got our human eyes, our finger, our feeling, everything to adopt on even without any haptic feedback is actually better this way because the haptic feedback have to be very accurate. So for us, it probably no need. But then it will be required for the future automated robotic procedure to be conducted in a safe way. You need a haptic feedback, you need the AI, you need the better imaging. Everything has to be coordinated. But added together, it's increased cost. So technologically, you need to bring down the cost of all this. But then not now, in the next 10 to 20 years, I think all this technology will be cheaper and cheaper. So that might actually give you a leeway to go. But of course, you also need to understand that the robotic surgery is only the final procedure, that it will become automated or semi-automated, because basically if the public is not accepting automated driving, then it will never reach the point of automated surgery, because surgery is on the personal life. It's not only about the simple driving, social life.
Yeah.
So I think we'll see a trend towards automated driving before anything happens for automated surgery.
Absolutely. So definitely a big no to the question when we say that are the machine going to take up my job as a surgeon? So it's basically no. Yeah.
I trust that even currently when our flight is automated, there's always still a pilot, and it's not just one pilot. Actually, 2 or 3 pilots there. So to ensure that everything is safe.
It's safe, absolutely. Yes, Aung, please.
Thanks, Prof, for your very insightful and then the visionary kind of discussions. I really appreciate it. I think future is a digital surgery is a way to come for us, and then how we should embrace it. And then with the technology advancement, sensing and all these things, right, I think the surgery might be the future frontiers. I think regardless, the healthcare is to look after the patients who are human. And then we as a human is the emotional needs, everything I think is still not replaceable. I think so. For us, we need the how to bring up our soft skills, especially for younger surgeons there, right? Even with the advancement of technology can help and enhance the care model, but I think we still need to embark on the so-called human touch in our healthcare delivery as well. I think we are also short of time. I think probably the last question for Prof.
Yeah.
Recently, Prof, I remember I read your publication in the Chinese University of Hong Kong about your life as a dean after you took up the deanship in the university. I know you as a very visionary leader, also as an innovator, researcher, and a clinical educator, clinician scientist, you name it. I think you have all the being a role models of all these aspects. So I think I would like to request your wisdoms or share your wisdom to all of us about how you manage the time with all these wearing the different hats as your role in the leadership roles. I think this is something amazing. I still with the current situation, I still struggling myself. So I think a lot of people will learn from your that aspect as well. Thank you, Prof.
Yeah. Thank you. So in fact, time is not enough for me always, but I adopt some kind of interesting way, because maybe also good for the younger generation, because I usually when I'm doing a work, I am in parallel doing other works. So this is one of my secret I can share because, for example, currently in my desk, I have 2 screens, including the computer will be 3 screen. Usually I open 3 things in this 3 screen. I do, maybe paper writing for 5 to 10 minutes. I prepare PowerPoint on the other screen, 5 to 10 minutes, and then I read something on the next screen, and then I come back. So this is my usual workflow. I like to, do things in parallel. And sometimes as a dean, you also need to do that. For example, in a meeting, you probably need to answer many messages from different people because in the institution, in the faculty that I'm managing, it's not only faculty medicine. I have 5 schools under the faculty medicine. So there's usually a lot of things that happening during a meeting. So I have been, this kind of mode of life have been like for me ever since I was a child, and I like the Chinese painting. But for Chinese painting, you need to paint one, for example, a flower, but you cannot continuously paint because you need the color to dry up. It's a watercolor before you can go to the next step. So what I do is I paint one time and then let it dry up. I do another thing. I come back to paint and I do another thing. So this is already like a training. But I trust that every surgeon is also something like that. So when you are doing the operation, you'll be called by somebody, and then you have to, answer that and then continue the operation. And sometimes you also may need to answer some administrative, call from other, your secretary, whatever. So I trust that everybody's like that. How do you make good use of your time? And also, how do you actually have a good planning, as is important? So planning actually took up most of my time. But if I do the planning well, then I can just do a one goal and then complete the task. Just like any surgery, planning is so important. If you do a good planning, then your surgery will be 100% accurate. It's what you plan by preoperatively looking into the patient, the imaging and everything. And then your surgical outcome will be good. The patient will actually be recovering well from your surgical operation. So I think my motto is that all surgery can only be done one time. There's no second chance. So do the right thing, do or do not, there's no try from Yoda. So all surgery is like that. I trust that that is the motto that I always like to share with a younger surgeon.
Thank you so much, Prof. Thank you so much for the valuable time and the advices. We are very grateful to have you as a mentor onto the group on our channel platform. It's basically being live onto the YouTube channel as well. All the audience are watching you. Before finishing the session, just a last piece of advice you want to give to the young endoscopic and robotic surgeon who want to pursue their career into the endoscopic and robotic surgery, and the last piece of advice you want to give on, and then we'll conclude the session afterward.
Thank you. As a surgeon, I think that the principle is probably like Chinese Kung Fu. Practice makes perfect. If you want to be a good surgeon, you must focus on every single step of practice. So if you cannot actually have a high volume, which most surgeons do not, you just go back and watch your own surgical operation video 10 times. For one patient, if you watch 10 times, you will find an area that you can improve for yourself. Then you can improve. So there's many work. So practice makes perfect. As an innovator, I think the advice is that everything you can imagine is possible. It's only whether you dare to dream. So very importantly, everything that a human can imagine will become a possible way. There's a lot of hurdle or difficulty. But if you can overcome all this thinking a good way, then everything is possible.
Thank you so much. Thank you. I hope our audience must have enjoyed it. And we are concluding to the session. Before conclusion, closing remarks, Dr. Aung, if you want to add on, please, anything. And then we will close the session. And we'll say thank you to Professor Philip Chiu as well.
Yeah, thanks. Yeah, so actually, personally, I mean, every time I told Prof that every talk I attended for his talk, I learned a lot of new things. That is the truth. And then that's why I think Prof and I has been discussing how to have the webinar, and then all of us can be here. It is really my honor to sort of co-host with you for the Professor Chiu, right? And then thanks a lot for Prof. Despite your very busy schedule, you give us this 1 hour time. It is really it's a golden hour for us, for especially for us, younger generation, and as well as the ELSA, for us. Yeah. So I think without further ado, I think now I really to sincerely thanks Professor Chiu for your time, and then the hopefully we can have more sessions and then learn from you more in the future as well. And then hopefully all the whoever viewing live or from the channels, I think hopefully we can have a very good learning opportunity from Professor Chiu today's discussions. Yeah. Thank you.
Of course. Thank you. Thank you, Aung. Thank you, Professor Philip Chiu. And thank you all the audience being with us today. It was very deep learning, just like the deep learning of the robotic, to learn about the technology merging with the surgery and how you can cope and learn the different skills in terms of the overcoming your learning skills, of future robots, ethical concerns, especially learning it directly from the Professor Philip Chiu is indeed in itself is a great experience. Again, thank you, Professor, for being with us as a mentor, as a host, and as a guest of the stage. And we'll stop our recording here. See you next time. On the 4th episode, we will share it soon. The recording would be available if you want to see it again, would be available onto the ELSA YouTube channel. And you can download the ELSA app, and that will basically is incorporated with all the upcoming interviews and the previous interviews, and also about the all ELSA activities in terms of the minimally invasive surgery, as well as the ELSA educational activities. Thank you so much.